Hello, welcome to the Self-Learning Podcast by Dr. Sushma Singh. Let us start discussion on Unit 9, Partnership among different levels of government, local authorities and special purpose agencies. And our topic is Partnership among local authorities and special purpose agencies in health sector. Improvement in the health status of the population has been one of the major thrust areas for the social development programs of the country. This was to achieved through improving the access to and utilization of health services with special focus on the underserved and the underprivileged segments of the population. Over the last 5 decades, India has built up a vast health infrastructure and manpower at primary, secondary and tertiary care in government, voluntary and private sector. These institutions are manned by professionals and paraprofessionals trained in the medical colleges in modern medicine and ISM and H and paraprofessional training institutions. The population has become aware of the benefits of health related technologies for prevention, early diagnosis, and effective treatment for a wide variety of illnesses and accessed available services. Technological advances and the improvement in access to healthcare technologies, which were relatively inexpensive and easy to implement, has resulted in substantial improvement in health indices of the population and a steep decline in mortality. The extent of access to and utilization of healthcare varied substantially between states, districts and different segments of society. This to a large extent is responsible for substantial differences between the states in health indices of the population. During the 90s, the mortality rate plateaued. Country entered an era of dual disease burden. On one side, there are communicable diseases which have become more difficult to combat due to insecticide resistance among vectors, resistance to antibiotics in many bacteria, and emergence of new diseases such as HIV, for which there is no therapy. On the other side, increasing longevity and the changes in lifestyle have resulted in increasing prevalence of non-communicable diseases. Undernutrition and micronutrient deficiencies and associated health problems coexist with the increasing prevalence of obesity and lifestyle related non-communicable diseases. Unlike the earlier era, the technologies for diagnosis and therapy are becoming increasingly complex and are expensive. It is likely that the large investments in health will be needed even to maintain the current health status, because the technology required for tackling resistance infections and non-communicable diseases are expensive, and this will inevitably lead to escalating healthcare costs. Now let us move to the next point, current problems. Persistent gaps in manpower and infrastructure in government sector, especially at the primary health care level, in remote, rural, tribal and urban slums areas where healthcare needs are greatest. Suboptimal functioning of the infrastructure, poor referral services, plethora of hospitals in government, voluntary and private sectors not having appropriate manpower, diagnostic and therapeutic services and drugs. Technological advances which widen the spectrum of possible interventions. Increasing awareness and expectations of the population regarding health care services and escalating cost of health care, ever widening gap between what is possible and what the individual or the country can afford. Faced with the problems of a suboptimally functioning healthcare system and providing adequate investment for improving health, the ninth plan emphasized the need for reviewing the changing the health scenario and assessing the response of the public, voluntary and private sector healthcare providers as well as the population themselves to the changing situation. Reorganizing health systems so that they become efficient and effective. Introducing health system reforms which ensure access to public health programs free of cost to all and enable the population to obtain essential health care at affordable cost. Now let us move to the next point, National Health Policy 2002. The National Health Policy 1983 provided comprehensive framework for planning, implementation, monitoring of health services and goals to be achieved by 2000. The Department of Health has reviewed the performance since 1983 and formulated the NHP 2002. NHP 2002 emphasizes that any significant improvement in the quality of health services and health status of the citizens would depend on increased financial and material inputs. Service providers treating their responsibility not as a commercial activity but as a service, the citizen demanding improvement in the quality of services, a responsive health delivery system, particularly in the public sector, and improved governance. Reorganizing that the health needs in the country are enormous and dynamic and financial resources constraints. The NHP 2002 attempts to make choices between various schemes and has set the goals for the next 2 decades. It is expected that with effective implementation of policies and strategies indicated in the 10th plan and NHP 2002, the country will achieve goals set and demographic transition within the set time frame. Now let us move to the next point, privatization of health services. The most significant and widespread global trend in the healthcare over the past decade and more has been the increasing share of for-profit healthcare and its marketization across the societies. This process in the healthcare sector has paralleled the process of economic globalization and is intrinsically linked to it. While private medical practice and the dispensation of medical care for a price have been known for a long time. The commercialization, corporationalization, and marketization of healthcare are a phenomena of the last quarter of the 20th century. The process received a boost during the late 1970s and early 1980s, thanks to a global recession, which enveloped both developed and the developing countries, imposed physical constraints on the government budget, and encouraged them to cut back on public expenditure in the social sector. This increased the space for the growth of the private sector in providing of health care. Given the fact that the multilateral agencies have an influential role in shaping national policies, particularly in the health sector, multinational corporations and systematically targeted them for policy influence, defining priorities for disease control programs, provisioning of health care, medical research at the national level. Typically, MNCs have influential national policies in key areas such as provisioning and research in health care through multilateral agencies like World Bank, World Health Organization, and World Trade Organization. Through the bank, they have influenced the development funding in the social sectors, securing focus for programs with a higher curative content. In India, at the time of independence, there was a significant presence of the private sector, which was dominated by individual practitioners. As per the estimates of the Bohr Committee, the proportion of allopathic doctors in private practice was 73% and the remaining 27% were in government service. There was no effort by the government to curb the growth of the private sector. The proportion of private nursing homes and hospitals was insignificant at the time of independence. However, these institutions started growing during the 1970s and were restricted to urban areas and states where there was capitalist growth in agriculture. The cutback in public spending coupled with the government subsidies has resulted in the growth of the private sector at secondary and tertiary level of care. In India, it is mainly an urban phenomena, but in services in peri-urban and even rural areas. This is seen in Andhra Pradesh, Kerala, Maharashtra, Gujarat, Punjab, and Haryana. In these states, the proportion of private bed is higher than public bed. Most other states like Bihar, Uttar Pradesh, Rajasthan, Orissa, and West Bengal witnessed little private sector growth during the 1980s and 1990s. Now let us wind up the session and take rest. Thank you very much for engaging yourself with the self-learning podcast.